We are in Chapter 2, Diabetes. When we are looking at diabetes, you probably know someone who has diabetes. So let's look at that and let's be honest about what the diabetes prevalence is. You have job security because the CD says that 1 out of every 3 Americans born in the year 2000 are likely to develop diabetes. Now we're going to learn the difference between type 1, type 2, gestational diabetes, etc. today. But what is diabetes? It's just a chronic disorder. It requires long-term lifestyle changes of both diet and physical activity. So we're seeing some commonalities. Every time we're going to look at any different disease state going forward, we're talking about manipulating 2 variables, their diet and their physical activity. So with diabetes, there's a relative or complete lack of insulin secretion by the beta cells, or there's a defect in the insulin receptors. So this results in disturbances of carb, protein, lipid metabolism, and an elevated blood glucose. So when we started the class, we talked about obesity as it was growing, and we thought in 1994 here the diabetes prevalence corresponds with the obesity epidemic, because when someone's overweight they're more likely to have type 2 diabetes. Sometimes we call it diabesity. So we're going to look at this in just a short second, but 36 states had a diabetes prevalence of less than 5%, 1994. In 2005, the numbers are higher now, the state we're looking at a prevalence. Look at the South. Again, Florida, we're holding the line because our obesity limits are a little lower. So here we have between 1994 to 2005, we've seen the trend in the growing obesity epidemic. But when we started, we looked at here's here's obesity epidemic, and here is diabetes. So we're going to find that there's a correlation between being overweight and a higher risk of diabetes. And we come back to what we talked about in energy balance. We talked about the waist to hip ratio. So you're going into an area where there's job security. So we're going to learn the other variables that lead to an increased risk of diabetes. And it costs a lot. If someone has diabetes, it costs a lot more. So we're looking at all of that. And obviously, prevention is the best thing. So what are the different types of diabetes? We have type 1, that is also called insulin dependent diabetes. Some of your older physicians will refer to that as that. Type 2 is lifestyle. That is where they make insulin, but they don't make enough for their increased size. It was formerly called non-insulin dependent diabetes. Then we have gestational diabetes, and we touched on that when we did nutrition and pregnancy. It's diabetes that shows during pregnancy, not all pregnancies, due to the increased weight gain. And so at 24 to 48 weeks, we usually test their blood sugar. So we have impaired glucose tolerance and impaired fasting glucose. Now, sprinkled throughout your notes, I have live hyperlinks. I highly suggest you watch it because, 1, you watch a lot of videos, and 2, videos really help to illustrate the different topics that we're talking about here. This used to be called pre-diabetes, and we've actually lowered the guidelines of what's acceptable with diabetes. We do the same thing with blood pressure and lipids. So we're beginning to be more effective in trying to prevent the diseases. Now, right now, someone who has pre-diabetes. There are more than 100 million Americans now are living with diabetes or pre-diabetes. And so that's 9.4% of the population. And you've even seen that manufacturers, they're even talking about skin creams for people with diabetes. They're targeting that market. So with type 1 diabetes, that's the least number of cases you'll usually see. It's sudden, severe insulin deficiency. It requires insulin to prevent the negative state of ketoacidosis, coma, and of course death. That's about 5 to 10% of all cases. So most of the people you will have type 2. But with type 1, remember, there are 2 things that are basic hallmarks if it's a test question. It's immune-mediated, cellular-mediated autoimmune destruction of the beta cells. Usually occurs in childhood or adolescence. The less common is the idiopathic, where there is no known cause. So with type 1, the onset is rapid. The classic symptoms, I'm drinking so many fluids, but I'm losing weight. You're constantly thirsty because the hallmarks of type 1 diabetes, where we would test the blood sugar, increased thirst, urination, unexplained weight loss. So with frequent urination, dehydration, when someone has a gum bladder infection, a cold that doesn't go away, these are symptoms that are usually hallmarks of diabetes, so we would want to test their blood sugar. If someone's had 3 urinary tract infections in a year, besides the hygiene discussion, you need to look at where their blood sugar is. When they have wounds that won't close. With type 1 diabetes, gradual reduction in the beta cells in the pancreas. So they lose the insulin production. Sudden times, it's sudden and the onset is rapid, but many times it's a 6 to 12 month honeymoon period. So you may be working in a pediatrician's office and you're noticing some factors, like a cold that doesn't go away, they keep getting sick, and you test their blood sugar and lo and behold, it might be type 1. So type 2 diabetes, they make insulin. We call it insulin resistance. That means they're overweight and so they make insulin but not enough for their increased size. They have inadequate insulin production for their size. If we get them to make lifestyle changes, diet and exercise, we're going to see a reduction in that. That doesn't mean they can go off medications, but isn't the goal not to need as much of the medications if you do? And it's occurring in epidemic portions. That's most of the cases. Someone goes, oh, I have to go take my sugar pill. They're talking about the fact that they have type 2 diabetes. That's 90 to 95% of all cases. And a test question, the hallmarks of type 2 usually occurs after age 40. With type 1, it's usually in childhood or adolescence. With type 2 diabetes, most children with type 2 diabetes, and there are a growing number of them, are overweight or obese. So they're making insulin, but they're not making it for their increased size. And so if we get them to be more active, that's going to help them to use that extra sugar. And so if you're a school nurse, you're working about not only with children with type 1, but type 2, and working on making changes in their lifestyle. If a patient has diabetes, I don't care if it's type 1 diabetes, type 2 diabetes, they have a risk factor for heart disease. And we covered that when we did cardiovascular disease. But if someone comes in and they have diabetes and their lipids are normal, we still treat them like they have heart disease. What are we more likely to die of? Heart disease. So when you did article review 1, everyone tends to use different articles, things that you found interesting. My last spring semester, students were just so upset. There was a toddler diagnosed with type 2 diabetes. We said it's usually over the age of 40, but here we had one of the youngest children. They were obese, and I'm not even going to tell you how much they weighed because some of you would be appalled. So when you're looking at it, we have to intervene earlier. And its lifestyle changes. Now, the cases of type 2 diabetes in teens have significantly increased. Why? People are gaining more weight. And people don't care that they're gaining more weight. So now pediatricians are screening. They're having the discussion about getting a physical activity, or at least they're supposed to. So with type 2 diabetes, it's associated with metabolic syndrome. We touched on this and we did cardiovascular disease. Metabolic syndrome, you think about spare tire, right? You're carrying more weight in your abdominal region. Because we said when you carry more weight in your abdominal region, higher risk of heart disease, cancer, diabetes. If a patient has metabolic syndrome, is it more likely in men or women? What do you think? More likely in women because we have more body fat to begin with. So if someone has metabolic symptoms, they are going to have poor wound healing, blurred vision, recurrent gum or bladder infections. That might be something, your dentist might be one of the first to diagnose some conditions, and one of them might be that you have a recurrent gum infection. They encourage you to see your doctor for blood work. You could also be asymptomatic, and it's not always that easy. So with gestational diabetes, they had normal blood sugar prior to pregnancy, but now they are pregnant, so they have carb intolerance of varying severity. It's about 2 to 5% of all pregnancies. Now that number is probably going to grow because we have more people entering pregnancy overweight or obese. So that increases the likelihood plus a genetic tendency. So right now, if a woman had gestational diabetes with one child, that doesn't mean she'll necessarily have it with another. But either way, any woman who's had gestational diabetes is more likely to develop type 2 diabetes later in her life. Is her infant more likely? Yep. So we're looking at blood sugar control as the most important, no matter how you look at it, no matter whether you have type 1, type 2, gestational diabetes. And if we're looking at pregnancy, we want an infant free of congenital abnormality of normal weight. And so that means that we need to have good blood sugar control during pregnancy. So pre-diabetes. If we are doing health fairs and we're doing screenings, many times people are identified, and that's not unlikely because patients are considered to have pre-diabetes if they have impaired fasting glucose or impaired glucose tolerance. We identify it through fasting blood glucose or an oral glucose tolerance test. So metabolic syndrome, again, weight around the abdominal region, abdominal obesity. Dyslipidemia, your lipids are high, especially like your LDL. Your blood pressure is higher than normal. They're usually carrying extra weight, so if they get them to make the lifestyle changes, that reduces the risk. So lifestyle changes can reduce the risk of progression of type 2 diabetes. So metabolic syndrome, you need to truly have that in the chart. And a lot of times patients have it and they don't seem to put it in the chart around here. But metabolic syndrome means 3 or more of the following. Fasting plasma glucose greater than or equal to 100. We're back to waist to hip ratio, right? A man with a waist greater than 40, women greater than 35. Reduced HDL, less than 40 in men, less than 50 in women. Women after menopause, that number is going to decline, so we still look at that. Hypertension, greater than or equal to 130 over 85. Now, we're looking at hypertriglyceridemia as well. So you need to have 3 of 5 of the following. And many of your patients will click off many of these, more than 3 of them. So as we said, as we get older, we have more body fat, unfortunately, and women have more body fat to begin with. So women are more likely after about age 60 to have metabolic syndrome. It doesn't mean that they abandon all hopes of lifestyle changes. It just means it's a little harder for them. So, you know how people were talking about hypertension, silent killer? Well, now in a lot of news studies, they're talking about metabolic syndrome being a new concern because no one talks about it. They're not even identifying that a patient has it. But if you have a patient with abdominal obesity, hypertension, elevated insulin resistance, these are all hallmarks that we need to make lifestyle changes. So, these women are smiling, so you already think they're happier and healthier, but you don't have to be a perfect size. It means that you're exercising on a regular basis. That reduces your risk of metabolic syndrome. All these ladies would have it. Heart disease, type 2 diabetes. You never go wrong if your doctor's cleared you for exercise and healthy eating. So we have new research, and so the guidelines have said the Center for Disease Control, American Heart Association, American Medical Association are trying to reduce the risk of type 2 diabetes. Let's identify them first. But right now, 90% of over 86 million Americans have prediabetes and they don't know it. Now, no one ever likes going to the doctor and finding out bad news, but we're going to be able to reduce their risk if we do that. Genetics. Did that affect our weight? Sure. We can't change mom and dad, but we do know that there is a genetic predisposition for many diseases. Diabetes is one of it. If you have a genetic predisposition in your family genes, if you're overweight or obese, it's going to increase the likelihood of developing diabetes, of course, type 2. So if you have a family history, you may have gene mutations and you may inherit insulin resistance not related to obesity. In other words, it's not extra weight. Sometimes the genetics is just so strong. So when you're looking at your reading, we have the diabetic genotype that could have developed during primitive times, and that was for survival. But then you survive, abundant food, and now the more efficient use of limited food during times survival is not really a concern. So as the food supply became more plentiful, the thrifty gene, aspects of it became more negative. Star asterisk no. Who is a high-risk population? Hispanic, Latino Americans, Asian Indians, Pacific Islanders, Creoles, South Asian, Pima Indians. These are all high-risk population. So I can be working with an endocrinologist and I'm reading the doctor's evaluation and he says John Junco's of Pima Indian descent. It's not because he's into ancestry. He's talking about Juan has a family history. He's Pima Indian descent. The American Diabetes Association has special targeted programs to each one of these groups because we know that we're going to look at cultural sensitivity, we're going to look at their diet. We know these are high-risk population, so we have programs like Sweet Sisters and so on out there to help. So if we're looking at the estimated age-adjusted prevalence, we are noticing that there are certain profiles, and this just corresponds with what we said before. So when we are looking at it, we know there's certain populations, so we specify them and we intervene earlier. If someone's at a higher risk genetically, just like with cancer, you would intervene earlier. So if we're looking at diabetes, immune-mediated autoimmune destruction, type 1, increased thirst, increased urination, increased hunger, weight loss. Example, you're working in a pediatrician's office and Johnny comes in and you've known Johnny and his mom for a long time. Well, the mom's frantic. She's got to get him in. He's got this cold that won't go away. He's drinking water all the time. He's eating, but he's losing weight. You're very concerned. And of course, like all parents, they're probably going online, looking at whatever it might be. So with type 1 diabetes, when Johnny comes in, you notice he's lost the weight. And when you're talking with him, he has a fruity smell. He's in ketosis. Remember that negative state. He's tired all the time, but he's eating. Why? He's basically urinating out his calories because the symptoms occur because glucose is not used for energy. It's just filtered in the urine for an excretion. If you watch the video links in there, you can see exactly how that works. Our patient with type 2 diabetes are coming in for annual physical, let's say they're 32, and we just do the routine panel so we find out where they're doing. And they could be normally fine. Sometimes they have wounds that won't go away, recurrent gum or bladder infection. They can see the eye doctor. Sometimes the eye doctor is the first to notice hypertension or the blurred vision might be related to blood sugar. Now, if someone has type 2 diabetes, we can turn this around if we intervene with, guess what, lifestyle changes. So initially it was thought to be a disease of carb metabolism. That's when the exchange systems came out around 1950. But now we know it's a metabolic disorder resulting in lack of insulin, and it affects each basic nutrient, but it's especially carb and fat. What is normal blood sugar? This is like a retread of chapter 2. Normal blood sugar is 70 to 120. That's the range we need, right? So we have vital, overall fuel metabolism and other metabolic functions. So we can get courses of carb, and this was chapter 3, and we talked about carbohydrate. We have carb in each of our food groups, but we also have our glycogen in our muscles and liver, and it is there to store our energy. So the conversion of our stored energy for blood glucose, let's say your NPO after surgery, is important. If we have too much blood sugar, then it's converted to prevent the continued rise or excursion of your blood glucose level. So we have 3 mechanisms. Glycogenesis converts glucose to glycogen. Lipogenesis converts glucose to fat for storage in adipose tissue. And glycolysis, cell oxidation of glucose for energy. So we're knowing type 1, review, genetics involved, yes, definitely. Type 1, autoimmune destruction, heredity, could be viral infection, that's the least number of cases. Most of your patients will have type 2 diabetes, so we're talking about lifestyle changes. Lifestyle changes are good for everyone, right? Even someone with type 1. But they have insulin resistance. They make insulin not for their increased size. They're couch potatoes, so we introduce them to the joys of exercise. Their blood pressure's not under control, so we have them see their doctor and they control that. They're overweight. Their lipids are higher. So hormones are involved. We did it during each of the different macronutrients, and now we're back to the same thing. So we have types of islet cells in our pancreas. The alpha cells make glucagon. About 30% of it make glucagon. We'll get more detail on each one. Beta cells, about 60% make insulin. And delta cells, about 10% make somatostatin. So insulin, it's the one that you've learned the most about probably in your biology classes, but remember, it facilitates the transport of glucose through cell membranes by the way of our insulin receptors. So it enhances the conversion of glucose to the storage form of glycogen. It also stimulates the conversion of glucose to fat. Again, video links of exactly how it works, and the videos really are very good. So with insulin, it also keeps everything in balance, right? So it inhibits fat and protein breakdown. It promotes the uptake of amino acids in skeletal muscle, and it influences glucose oxidation through the main glycolytic pathway. So how do we keep this in check? We have glucagon. It balances. It's the opposite. It's the antagonist of insulin. Oopsie, I gave myself too much insulin, then we have to treat with glucagon to keep the control. If we have a rise in the blood sugar, not good, right? And we need to protect the brain, so glucagon comes into the rescue. Now, it also helps maintain normal blood glucose levels while we sleep or we're fasting. It also helps with the breakdown of liver glycogen. Everything needs to be kept in balance. So here's where the hormone somatostatin kicks in. It inhibits interaction between glucagon and insulin. If we're looking at the metabolic changes, remember blood glucose cannot be oxidized through the main glycolytic pathway. It would build up in the blood. Negative, right? So we also talked about, and we did carb and we did lipid, and we said carb is protein sparing. We also talked about ketosis because fat breakdown increases the formation of ketones, a negative state. You can test them with their little keto sticks, leading to ketoacidosis. Remember, Johnny had that fruity breath. So our tissue protein is broken down to secure energy. So we're not giving the body what it wanted, and that causes weight loss and nitrogen retention. So how do we manage it? Have a healthy diet, exercise. And we need that, especially with a child, so that they meet their growth potential. We need it for a pregnant woman so she has a desirable outcome. We also know that we're trying to manage someone's blood sugar. We want to keep it in that range we want, but we don't want to have hypoglycemia too low, hyperglycemia. And that's a delicate balance that we're always trying to orchestrate. If we don't keep the blood sugar under control, well, now you're going to end up with complications. If you've known someone who has diabetes and they haven't monitored it, they may have problems. They have wounds that won't heal after surgery, kidney damage, nerve damage, retinopathy, peripheral vascular disease, heart disease. Remember, once somebody has diabetes, they already have a risk factor for heart disease. So if we are looking at kidney disease, eyes, nerve, arterial stiffness, these are all hallmarks of not controlling your blood sugar. And look at type 2 diabetes is more negatively impacted than type 1. And most of our cases are type 2. So you see all those dialysis, those wound care centers opening up because we have an increased population with type 2 diabetes. When you have a wound that doesn't close, or maybe you're obese and you haven't seen the bottom of your feet in a while and you just feel something down there, or maybe you don't feel at all. Foot ulcers are a common complication of diabetes. The blood circulation's impaired. The blood isn't getting there. It's not healing. They have nerve damage. Their feet get numb. They delay the recognition of the cut. Oh, I didn't know I stepped on a tack. So everything we do, we come up with goals. We're individualizing for each patient. But when we're looking at it, we're looking at how we are going to manage it. So we're going to be talking about food habits and exercise, basically a culmination of what we talked about to this point. If someone needs to take insulin, we don't just kind of wait and say, yeah, kind of follow it. We're aggressive. We want tight control of the blood sugar, and we'll talk about that. And we also know that self-monitoring the blood glucose is one of the biggest things that they can do besides lifestyle changes. So we can educate somebody, but ultimately it's up to them. The self-discipline and informed self-care, we can be sensitive to their needs, but they must treat themselves day in and day out. They're not going to have us there helping them to determine how much they're going to adjust their insulin for whatever they're going to eat. So it's a comprehensive program. And if you've ever known someone who has diabetes, whether it's in a hospital or now increasingly they're more in line, a lot of people kind of drop out halfway. They just lose the momentum. But you need comprehensive care. You always need to have a teachable moment every time you go in. Give them a new little nugget of things that are going to help make their lives better. So frequent blood sugar control is the most important. Now, if you know someone who has type 1 diabetes, more than likely they're not using the insulin injections, they are using the pump. And the pump is paid for because you get tighter control of your blood sugar. But as I said, ultimately it's up to the patient themselves. Johnny's a preteen now and he wants to go to his best friend's house for a sleepover. If he's your child, would you let him? Well, children that have had type 1 diabetes are remarkably able to manage their blood sugar because self-monitoring will keep their blood sugar under control. And if he's visiting his best friend, he probably has been over there, and I'm sure the parents are texting back and forth, but there's really no harm in that. And he can play pee-wee football, whatever it might be. Type 1, type 2 diabetes doesn't matter. Regular exercise is going to really help them to better control their blood sugar and, let's face it, to reduce their risk factors for heart disease. If someone has type 2 diabetes, it'll prevent the extra weight gain. If someone has insulin therapy, we need to constantly change it. Things change, patients change, lifestyles change, sports change. So we need to talk about the different types of insulin. We'll be doing that in a little while. If a patient has diabetes, whether it's type 2 or type 2, and you're insuring them, are they going to live as long? No. If a patient has diabetes, they're not going to live as long as their sibling who does not have diabetes. So when we counsel someone, we individualize it for them. Who is the patient? What is their lifestyle? So we're looking at lifestyle factors. Are they a swing shift kind of worker? Are they a vegetarian? Or are they an omnivore? We need to have consistency. I know at Thanksgiving or people eat like one big meal and they're not considering what their blood sugar control is. And so most recommendations are the same, whether it's type 1, type 2. And so we modify it for protein, carb, sucrose, and alcohol. So with type 1 diabetes, your book talked about the diabetes control and complications trial. Basically, this was a study. It was over 10 years with real people, and we found that the old conventional therapy versus the intensive insulin, meaning pump, resulted in fewer complications, microvascular, than the conventional therapy, which, by the way, when I did my internship was cutting edge. But now, things change. And so we know we want tighter control of your blood sugar, and the pump is going to be intensive insulin therapy. Our goal is to keep your blood glucose level in your diabetic patient to less than 7. Most of them come in, they're uncontrolled, they don't know they have the diabetes. And so we'll look at glycosylated hemoglobin, hemoglobin A1C, terms used interchangeably, but glycosylated hemoglobin will be on your test. From 9 to 7 will reduce the risk of complication. I'm going to give you a visual of that in just a minute. Now the conventional therapy, they lost a little more weight, but we also had more complications, so kidney, eye damage, or a few pounds, which is more important. Then we had the United Kingdom study where it showed treatments to improve blood sugar control and heart disease would reduce the risk of macular degeneration. Again, heart disease, #1 killer of all of us, morbidity and mortality, but especially in our patients with type 2 diabetes. So if a patient comes in, they're overweight, we talk about lifestyle. If they have type 2 diabetes and hypertension and dyslipidemia, they're considered to be independent risk factors. So we're going to be much more cautious on these patients, which is most of your patients. Gestational diabetes. We're doing what we need to have a healthy infant free of congenital abnormalities. But we also know that if we have an infant, macrosomia, big baby, that means that we didn't control their blood sugar. In other words, we failed. The risk of fetal abnormalities and mortalities rise when their blood sugar is out of control. So that causes macrosomia, big baby. Remember, insulin does not cross the placenta. The glucose does, which is why you have a big baby, because the glucose wasn't being controlled. We do what we need to do to control someone's blood sugar, and that may include insulin, whether it's type 1, type 2, or gestational. Every patient is individualized, so we individualize it for them. Now, of course, diets and nutrients need to meet the needs of a healthy pregnancy, even if she's obese. And we also need to have consistency in our maternal blood glucose goals. So we want to look at monitoring your blood glucose at least 4 times a day. I'm not going to test you on these. These are numbers you can learn for many of you when you go into your nursing program. Everything we do is to make their lifestyle change and to make it a little more easier for them to have good blood sugar control. Not too high, not too low, just right? And we also know that we're trying to manipulate their diet so that we help to keep their lipid and lipoproteins, in other words, their LDLs down, because that's going to reduce the risk of macrovascular diseases. Blood pressure control is important for all of our patients, but if someone has diabetes, it's like someone who has heart disease, we're going to be much more proactive as to how we're going to do that. We need to prevent and treat any complications. So, lifestyle changes. Our child with type 1 diabetes, we need to have them have enough nutrition so they meet their growth potential, right? And to keep their blood sugar under control. And that's just our 2 major goals. So we need to integrate our insulin regimens into usual eating habits and physical activities, no matter what their sports might be. You're a school nurse. You have a child in the school with type 1 diabetes and type 2 diabetes. Can they both have the school lunch? Can they both go to PE? Yes and yes. So we're trying to, with our type 2 patients, talk about lifestyle changes. It may not be happening at home, but talking about heating and physical activity will help to reduce their insulin resistance. Pregnant women, we want to have a healthy infant free of congenital abnormalities. That means she needs adequate calories for an optimal pregnancy outcome. Insulin does not cross the placenta, but the glucose does. And that's our big problem when we're looking at, that's why we test your blood sugar. These are your most challenging patients overall because eating is social, right? And so they've gotten to where they are and they're going to eat what they want. So, each one of our population groups has different changes. How would we treat them? If we have an individual with type 2 diabetes, we might treat him with insulin or anti-diabetic medications. But whether it's type 1, type 2, we need to prevent the hypo or hyperglycemia. If they're going to start exercising, they're going to play pickleball, growing sport in older population, we need to control their blood sugar. So everything we do is individualized for their lifestyle, and we want consistency. If someone was a meal skipper and they ate 1 meal a day, you're going to talk about mini meals or maybe snacking and trying to get more into more balance so we have better control of their blood sugar. So how do we control that? For many of our patients, it might require insulin. Intensive insulin therapy uses several types of insulin. So insulin could be used as an additive therapy to type 2 diabetes. That's right, you heard it right. If I have a patient with type 2 diabetes, they may need to take insulin because maybe their oral hypoglycemic agents weren't enough. Insulin is not just for type 1 diabetes. We do what we need to do to maintain a normal glycemic state. So with rapid-acting insulin, onset half an hour after the injection, stays in the body less than 5 hours, peaks at 2. Short-acting, onset half an hour to an hour after the injection, stays in the body less than 6 to 8 hours, peaks at 3 hours. Intermediate-acting insulin, onset 2 hours after the injection, stays in the body 20 to 29 hours, peaks at 11. Long-acting, just that. acts over 24 hours, but it cannot be used with other types of insulin or oral hypoglycemic medication. So here are the different peaks and troughs, and you'll learn this if you're going into the nursing program, but it's more than you need to know for this course right now. I want you to know intensive insulin therapy, think pump, requires multiple injection of rapid-acting insulin, or it's treated with intermediate-acting insulin. And you'll get tighter control over your blood sugar. Remember we had the exchange system, and that helps us to determine what our portion size is? Well, I said at that time each carb serving is equal to 1 unit of insulin. It's everything math, you know that. So the initial dose is 0.5 to 0.6 units of insulin per kilogram per day. Half for your basal need of your patients, half for your boluses. Now we get more complex, but we start simple, and I'm going to give you a meal plan in a second. But if you're having an English muffin, you think, and English muffins usually are not too distorted in size. So you can think of an English muffin. It has a top and a bottom. Each top or bottom is equal to 1 unit of short-acting insulin. In other words, each serving of a carb-based food has 15 grams of carb. So our exchange system, we're having fruits, vegetables, dairy, they all have carb. Now, fat does not. So insulin and exercise need to be controlled. If we're going to exercise a lot and you're going to start doing that, that's great because it helps on the insulin receptors of the muscle cells. So those 3 ladies we walk around that had metabolic syndrome, you know, 1, they're smiling, but 2, they're better using their blood sugar. And it also increases insulin efficiency. But it needs to be regular effective. So whether they're surfing, playing tennis, whether they're walking around the neighborhood, we know that if they're going to have heavier exercise, they're going to do a marathon, we need to accommodate their extra calories. Intensive therapy requires multiple injections. So when we are looking at, we're usually talking about, most of our patients now have pumps. And the pump is worn in a belt, has a subcutaneous meter, and you just adjust the medication that you need. Conventional. This is what we used to do in blood sugar when I did my internship. Now, intensive means we're testing the blood sugar at least 3 times a day. More data, better control of your blood sugar. Isn't that our goal? So with insulin therapy, they had 1 or 2 injections, but they didn't make adjustments. Now, tight control of the blood pressure. We're on it, right? We're doing intensive therapy. And that means we're going to have less retinopathy, neuropathy. Oral hypoglycemic agents, what our patients call their sugar pills, are for our patients with type 2 diabetes. And these are some of the typical medications you usually see. Maybe those medications don't work, and there are always new meds coming out, but medications don't always work for all our patients. So we may need to use insulin as an added therapy when oral agents are not always effective. So there are different drugs that are there. I know some of you like the little lizards out there. But we're always looking at new resources of where we can go, whether it's a bark or in this case, it's the saliva of Gilead monsters will increase our insulin receptors. So they're all medications, but when we are looking at some of the newer ones you're seeing like Byetta, you hear advertised all the time, they really don't have a risk of hypoglycemia, and of course they're more expensive. So when we are looking at it, we need to have added therapies for many of our patients to control their blood sugar. When we did eating disorders, I talked about diabulimia. If you're a teen and you want to fit in with your peer groups, as all teens do, one of the ways that many people fit into their cliques is with weight. If I have a patient with type 1 diabetes, when they're going through those phases, I'm going to be cautious about an eating disorder because diabulimia means that they don't take the insulin, so they lose the weight, so they fit in with their peers. Bad idea. Negative for their health. Self-monitoring of our blood glucose. Our patients have diabetes, so now they don't give you an extra luggage that you can take when you travel, but you have to have a small, easy, hand-sized meters. Now, there are newer things coming out, but it's not always covered for our patients. So with this You've all seen it in health fairs, or you've seen it with a friend as a reagent test strip. You insert it into the meter and you're testing to see how their blood sugar is. So we want more data, right? 2 to 8 tests. Children with type 1, very good at controlling their blood sugar. It's under their control. And so again, same thing with Johnny. Glycosylated hemoglobin. Your textbook uses the word glycosylated hemoglobin and hemoglobin A1C. They're the same thing, but if you're going to see a test question, it's glycosylated hemoglobin, so put that in your mind. Glucose attaches to our red blood cells, and we have irreversible glycosylation of the hemoglobin. So if I have someone's glycosylated hemoglobin, I know where their blood sugar's been for the last 2 to 3 months. So that's good, right? So we can tell whether they have tight control of their blood sugar because our glycosylated hemoglobin relates to the level of blood glucose over a long period of time, which means 6 to 8 weeks. Didn't we say 6 to 8 weeks is when we see changes in your lipid level, noticing parallels? Anytime we have a lifestyle change and we want to see it result in their blood work, it'll need to be at about 6 to 8 weeks. One day is not going to make a difference. So we're also talking about activity, and we want to check in with them and what kind of exercise are they doing, maybe talking about other type of exercises or maybe just prompting them to exercise. It helps them better control their blood sugar. So self-monitoring, one of the most important things along with adjusting their diet. Gestational diabetes, recap, happens in pregnancy. During the first trimester, we don't need any extra calories for women that are pregnant, but the second and third trimesters we do. So if a patient has gestational diabetes, we want them to have an infant free of congenital abnormalities of normal birth weight. So we're still going to have the same recommendations of what they need for their BMI, how many calories do they need. But what that comes down to, they need high quality protein, right? Hopefully they're an omnivore, so we can work on that. So we're looking at more folic acid. We said that you needed folic acid in your diet prior to pregnancy to prevent neural tube defects, but you need it throughout. And your prenatal covers it, but what's wrong with green leafy vegetables? They need enough calories. Even if they have morning sickness, we have to get the calories into them. They're growing a healthy child, right? So we need to prevent ketosis. So when we're looking at impaired fasting glucose, there are risk factors. If your blood sugar is out of control, we're going to treat you like you have heart disease. And the interventions are consistent with the Heart Association, the CDC. But if a patient's overweight or obese, we have many teachable moments and we can have a variety of things that we're going to talk about them with that. But it comes down to diet and exercise. Same thing that we've said just at about every chapter, and we're going to see it going forward, and improving their overall health. We're counseling. Every time we're talking with a patient, it's not like it's a conversation, but you get really good at giving them ideas of how they can make changes. So if we know a patient, we've assessed them, we have an idea of their lifestyle, from how much education they have, what things that they've done, and we get an idea of where they are going. But everything we do is individualized for each patient based on their diagnosis. And we also are proactive and we think about what things could develop in our patients. So we need to be appropriate giving them meal planning tools. We need to individualize it for each patient. So when we're looking at data, we always are looking at data. We're making adjustments. Oh, your blood sugar, your new medication, maybe we need to do this, maybe we need to do that. We're never happy. And just like an athlete, you're constantly working on your form, your time, whatever it might be. We're doing the same thing with our patients. There's always something new that we can share with them. So we select what works best for our patient and we tailor it for them. We make it as simple. Give them 1 or 2 actionable items that they can do. So the exchange list, I have the links for you, but if we were looking at the The security on my system is so tight it won't let me do it. But you have the exchanges there. And this is the University of San Francisco. And they have a good exchange list that's easy for most of our patients to look at. And all it talks about is carb counting. And I'm going to give you an illustration of what the basic skeleton is of what a meal plan is. Every time you eat something with carb, we know we need to control someone's blood sugar. So we're adjusting food, medications. So it requires a good understanding not only the healthcare provider, but the patient on intensive insulin therapy. So each serving is equal to 1 unit of short-acting insulin. It's 15 grams. So here we have a food, doesn't matter what the food is, the total carb is 31 grams. How many grams were in exchange? 15. So how many exchanges is that? Right, 2. It's not that hard. And then some people go, well, you subtract the fiber and you add the sugar. No, we only care about the total carb. That's the number that we use for the exchange. So with insulin therapy, consistent carb. You don't skip meals. You need small, frequent meals. That's always the default answer in our class, right? So, and then once we do that, we can get more complex, more fiber, more nutrient density. If Johnny came in and he was diagnosed with blood sugar, with type 1 diabetes, his mom just leaves and she's probably not listening to anything someone's saying because she thinks my child has diabetes. Did I cause the diabetes? And then she does more web searches on it. But you can't let the patient and his mom leave until you talk about what to do on sick days, because you still need food and insulin. You need to adjust it. This is why we can't just have one contact with the patient and know that they know all the skills that they need. With physical activity, if he's playing pee-wee football, you need to be able to help him plan the meals to have for the strenuous activity. If your child was diagnosed with diabetes, most people feel guilt, and that's probably normal. And so then Disney World, that's where we must go. So you need to self-monitor. You want to travel. Disney's a great place to go because they're pretty good about managing all of that. But on the way up to Orlando, you need to have meals. You need to have what you're going to have in the hotel. You need to be able to review the menu ahead of time to plan. Stress. Does stress make your blood pressure go up, your asthma get worse, your blood sugar go up? Sure. Stress needs to be managed. And emotional stress is going to be reflected in blood sugar control. So they know stress reduction activity. And remember, stress, hormonal response, it's an antagonist to insulin. So when we're talking with patients, it's not just politically correct. We are talking more about person-centered. Everything we're doing is talking about the patient. They're not the disease. They just have the disease. So we refer to them a person with diabetes. And we talk about adherence, not compliance. So when we are looking at it, if they are having difficulty, having a problem instead of cheating. Cheating is a negative. And so it's just you didn't choose the most nutrient-dense food. So we want them to be self-sufficient. They have to test their blood sugar. We want them to be able to make the better choices every day. So when we are looking at it, we're giving them the pros, the cons, what the experts agree or disagree, because they're going to come in with some outlandish things, and you need to be able to talk about all of that with them. So we want them to control their own health. So that means we talk about nutrition, exercise, basic meal plan, and monitoring their blood glucose. What to do when you're ill. How do you talk with your other healthcare providers? Should they see other healthcare providers like a cardiologist? Because if they have a higher risk factor, they're overweight or obese, do they need to be more proactive? So we give our patients education material, and increasingly they're less commonly printed out. It's more electronic, but you give them the reference source that you might have for your institution. Glycosylated hemoglobin. There's going to be a test question, maybe more than one. It is the substance in a red blood cell formed when our blood sugar attaches to hemoglobin. It's a test where your blood sugar's been the last 2 to 3 months. If I have a patient with type 1 diabetes, do they have a higher risk of heart disease? Yes. With type 1, it's immune mediated. And so our goal is to keep blood glucose level as close to normal. Same thing for type 2. But we know that if we reduce the glycosylated hemoglobin from 9 to 7, it can reduce the complications 50 to 70. So if our patients, their blood sugar's been out of control, they just do not care. They're a higher risk of eye disease, heart disease, nerve damage, stroke. Another question patients always have, can I drink alcohol? And that you refer that to the doctor. But you don't need alcohol to live, and we talk about what a drink is, what it's not. It's going to affect their blood sugar, and especially if it's a sweet drink, and never ever drink on an empty stomach. Never drink when you're pregnant, and we can go on and on with that, but you all know all of that. So when we are looking at it, men using insulin can add 2 drinks, women up to 1. This is a general substitution. Talk with your doctor. I don't think most doctors would agree with that. Fructose. Oh, we're back to the carb chapter again, right? It has the same nutritive value as sugar. It has 4 calories a gram, but we need to control it to about 75 grams a day. If we have a patient that's having a lot of sugar-free candies, it has a lot of fructose, and that has a large negative effect on their plasma lipid. Besides, they'll be very gassy and have diarrhea. So our basic control of our patient, if they have diabetes, type 1, type 2, gestational, impaired fasting glucose, our whole goal is the same, control their blood sugar. Their lipid and lipoprotein levels also have to be controlled. We have to be so proactive with these patients. Let's face it, all of our patients. The same thing with their blood glucose. So everything we do is not based on hearsay, what we see on the internet. It's expert consensus, clinical data on humans. So if we're looking at the American Diabetes Association, what is the most important thing? Blood glucose control. What is the most important thing? Blood glucose control. This prevents the complications of diabetes. So we touched on this early bit, but the diabetes control and clinical complication had real people, and it was randomized into 2 groups, the conventional and intensive group. So if we are looking at, they had major differences. If you had conventional therapy, you had more retinopathy, neuropathy, you had damage. On the other hand, those that were treated like a pump, insulin aggressive, had less complications. So everything we do is evidence-based, science-based on humans, and it's the total carb, not the source of them, that matters. Is sugar a great thing? No, but it's the total carb in their food. So when we're carb counting, we know that starches, fruits, milk, dessert. So if you had Raisin Bran, you put a banana on it, and you put milk, carb, 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 right? We're also knowing that our exchange list is based on 3 food groups, the carb, meat substitute, and fat. So if we're having milk on our cereal with the fruit, those were 3 different carbs. If we had the egg, then that would be a meat or meat substitute. So we make it easy. No matter who our patients is, we have the same template we start with. 3 to 4 servings per meal of carb, 4 to 5 for men, 1 to 2 for snacks. And then we get day-to-day consistency in there. And we want to test after their meal. Is their blood glucose less than 180? So carbs are not bad. They're not fattening. They don't need to be eliminated. If you have a brownie, it's not going to be the worst thing. But there are better things. You have it once in a while, like on your birthday. We already went over the exchanges, but again, this would be 2 exchanges. Each 15 grams is equal to 1. So whether we're having a slice of bread, a cup of milk, half a cup of juice, we can see the amount of carb that are in each of the food. Do you like rice? Do you like pasta? This is cooked. Have you ever measured out how much you serve yourself? Would you meet the guidelines of what carb consistency is? Because with our typical patient, we start with a 4-4-5 plan. 4 carbs for breakfast. I'm going to give you an illustration we'd use with Johnny. Lunch, dinner, and then a snack. And then we improvise from there. So he's a kid. He goes to school with cereal, milk, egg, toast, OJ. Yes, an orange would be better, but mom wants to get some food into him before he goes out. And here we can see how many carbs he has. At lunch, he has a school lunch. He has a tuna sandwich and a yogurt. Still within the 4 plan, right? Snack, he comes home, cookies and milk. Yes, they're better things, but he's a kid. Dinner, grilled steak, baked potato. That's about the size of your fist, or a white rose potato. A large ear of corn, that's the niblet size, and a salad. Then he has a snack. And so we're testing where his blood sugar is. So the most important thing is to control the carb. There are many things we know, but there are many things we don't. So we don't know necessarily how everything works, but what is the most important? We want to keep their blood sugar near normal. We want to keep their lipid levels down. If they need medication, they need medication. They're at a higher risk for heart disease. If they're children, we want them to meet their growth potential. So when we are looking throughout all of them, consistency, controlling your blood sugar, being accountable, writing down, or whether it's an app or whatever you use, and adjusting insulin based on your carb choices. So you need to integrate it. You can't ignore the protein and fat content of a food. We want nutrient density. Now we're back to chapter 1. So most of our patients are going to have type 2 diabetes, and most health professionals believe weight loss to be beneficial for patients with type 2 diabetes. Is it really? Obesity is associated with insulin resistance, high blood sugar, and glucose intolerance. So we need to have them control that, and the strategies may not be the same for every patient. Blood glucose control, high priority than weight loss. And I'm going to show you a chart that shows you why that is. So if we have a patient at risk of type 2 diabetes, their sibling got it, let's talk about lifestyle changes, physical activity, controlling their weight. So here's some strategies for type 2 diabetes, and I agree that blood glucose control and lipid control is the most important. Now if we look at this little rainbow of choices around here, are they all true? Really? New eating behaviors, true or false? True. Carb counting, true or false? True. Any restricted diet? There's no proof that's going to work. Smaller, more frequent meals? Always a good answer. Reduced fat intake, what do you think? Many of you have probably said yes, but reduced fat intake, I don't want them to have less omega-3 fatty acids. I don't want them to have less monounsaturated fat. There's no studies that show reduced fat. It's caloric density. Physical activity, yes. Blood glucose control. Add medications if needed, yes. Moderate weight loss, sounds good, but will it really work? And we found that a high population, you want someone to say, well, if you lose the weight, your blood sugar will come down. Studies don't bear that out. So we had 130 obese patients with type 2. They lost 20 pounds. Yay, we're so happy for them. But the majority of them didn't respond. Their blood sugar didn't go down. Isn't that frustrating when you identify that you hypothesize what's going to work and it doesn't work? So yes, eating a healthy diet and exercise is great, but that doesn't mean it's necessarily going to correlate with what the results are going to be. Our goal is to control their blood sugar, any macrovascular hypertension, any of that, and getting them to reduce their abdominal fat. So this will increase insulin sensitivity, which will help with the lipid. When you lose the weight around your abdominal region, you lower the risk. It also helps improve the glucose tolerance because you're exercising more often. You can't downsize the benefits of exercise. So if we have a dietitian and a patient with diabetes, the insurance will more than likely cover because it has a positive effect on their clinical outcomes. They'll have a 1 to 2% reduction in their glycosylated hemoglobin. And we know the studies in 6 weeks, 3 months, same interval with cardiovascular disease. That's how long it takes for your lifestyle changes to be resulting in your lipid works. Not doing anything. We want the glycosylated hemoglobin less than 7. This is unacceptable, right? Neuropathy, damage, nothing is going to be good for this patient. If they just have one visit at 6 weeks, 3 months, their blood sugar goes down, must have been a really good lesson, and then it reverts to the mean. But 3 will get us closer to 7. Again, we still want it less than 7. We want progress. Sometimes we don't get perfection. So if someone's glycosylated hemoglobin went down, Did they lose the weight? And there's not necessarily a correlation, kind of like the chicken and the egg. If we're looking at what studies show, carb is the most important thing. You don't need to restrict sugar. No, it's not nutrient dense, but food fiber is not going to make a difference. There's no proof of the glycemic index. I know it was in your textbook, but we eat a combination of food. You eat beans and rice, right? And there's no proof that organic, free range, unprocessed versus processed food is going to affect your blood sugar. A sugar is a sugar is a sugar. It doesn't matter if it's dextrose, rice, corn, potato. They all raise your blood sugar. People with diabetes are given many messages, and this is pretty much the same thing that we had. And you need to give them only fact-based information. Hearsay has nothing to do with what our patients are going to do, because we emphasize blood glucose control, not weight loss. That is the most important thing. Real foods, nutrient-dense food, exercise, keeping accountable, testing your blood sugar. I know when you're in school you think, well, I'm going to be so good, everyone's going to lower the weight, they're going to control their carb, but in reality, people do what they want. They'll listen to some of what you say, but lifestyle interventions are effective. It's just maybe not the same that you would hope. Sweeteners. If we have NutraSweet or Splenda or any of those, they sweeten the food more than what would be normal. So sulfosine K, I promised you in the energy balance how many packets, how many would be considered acceptable daily. Doesn't mean our patients need that much. So exercise, nutrient dense diet. The same diet we've been talking about, high fiber, lower saturated fat, is going to work for our patients. There's no proof that protein will affect blood glucose levels. I know people want to believe a lot of things, but just a few numbers. Right now, 24 million Americans about have diabetes, and that number is going to rise. You have job security. You've already learned that in this class. And many of our patients have impaired fasting glucose, impaired glucose tolerance, so every time we do a health fair, we usually have to send someone over to the hospital because their blood sugars or the blood pressure are just too high. It's unacceptable. Portion distortion. You can just put NHLBI, portion distortion. There's a video where it talks about how our portions have changed. This is a lender's bagel. There are two exchanges. There's a top and a bottom. If you go and you get a bakery store bagel, it's going to be more than 6 inches. Size does matter. Same thing with a tortilla. You're getting more calories. So you can't count them the same, especially if you're counting your carb. 20 years ago, today, lettuce, tomato isn't going to make a big difference. Pasta. Half a cup cooked is a portion size. And most people that you would consider this an appetizer, 500 calories, 1,000. So look at the calories, look at that, look at nutrient density, and you can see where we are going. Downhill, right? Isn't any wonder why more people are overweight? Muffins are cupcakes, let's face it. So we're looking at our questions that'll help you get ready. The most effective lifestyle interventions for type 2 diabetes are intensive insulin therapy, self-monitoring, avoiding sugar, substituting non-caloric sweeteners, using oral diabetic drugs or stress reduction, or weight loss and regular physical activity. Number 4. Normal range for blood sugar, 1, 2, 3, or 4. 3. People with type 1 diabetes can reduce their risk of diabetes-related complication using intensive insulin therapy, combination of different insulin, combination of insulin oral hypoglycemic agents, or a diet plan. Type 1, intensive insulin therapy, kind of code word for pump. What is the test that tells me what our patient's long-term blood sugar 2 to 3 months has been? Is it 1, 2, 3, or 4? 2, glycosylated hemoglobin. Okay, so that will end the video. I have all the links listed for you in your notes. Please view them. They are extremely helpful to understand the information.